if you're similar to me, it doesn't mean you're out of options. It just means you need to dig deeper and figure out where the problem is coming from. And that's where diagnostics come in, which we'll dive into now. So here's just a list of main tools diagnostics doctors use to understand airway problems. The last one hasn't been used outside of academia much and is yet to be adopted in practice. But each of these gives a different kind of insight, and together they help paint a picture of what's happening in your airway. So we'll go through them one by one. Hey everybody, so on to part 3, where let's say you've now been diagnosed with UARS, you went to a sleep lab that scores RIRAs, and you are looking for treatment. Well, what do we do now? And answering that question is tougher than it sounds, because I was first diagnosed over 10 years ago, and honestly, I'm still figuring out what works and what doesn't work. So in this video, I'll share what I've learned along the way, what's helped, what hasn't, and how to approach treatment in kind of a logical way. But this video will actually mostly focus on different diagnostic tools to be able to treat or guide your treatment in the right way, because I don't want to speak about treatment too much. I can speak about my own experiences, perhaps in a fourth video, but I don't want anything to be taken as medical advice. I'm not a doctor again, so please consult with your physician, your doctor, your specialists. So first of all, why is it so difficult to treat UARS? And that's something I've went into in previous videos, in the very first one of this channel, for instance. But essentially, in a nutshell, the medical system doesn't really know what to do with UARS yet. And many providers haven't even heard of it, and insurers often won't cover treatment. And even if they do, or when specialists have heard about it, they'll give you different solutions. So, an ENT might suggest surgery, a dentist might fit a mandibular device, and a sleep doctor, might suggest CPAP. None of them are wrong, but they're all just looking through different lenses, right? The challenge isn't just getting treatment then, because treatments are out there, it's figuring out which approach fits your anatomy and physiology best. And just to say up front, the first line of treatment is almost always CPAP, so doctors will suggest that for you, and for good reason. So it works regardless of where your airway collapses, because it splints the entire airway open. So pretty much everything else, any other intervention or surgery, MAD device, nasal stents, the hypoglossal nerve stimulators, or other types of implants, they all target specific problem areas. So unless we're talking about behavioral interventions, which are also super important, well, extremely important. So making sure you have good sleep hygiene, cutting out stimulants wherever possible, lifestyle factors, all that. But that's something I discussed previously. But going back to CPAP, and this is important, it just doesn't work for everyone, especially with a lot of people with UARS, So for some of us, it helps partially. For many of us, not at all. For some, it makes it worse. For me, it helped a bit, it never helped 100%, maybe 30 to 50%. It definitely made a difference. It got me through a lot of times, it got me over kind of a threshold from non-functioning to functioning. But I just had a lot of problems with it, and including pressure intolerance. So I can never reach the pressure that's actually the one that I need. So, and I've tried bi-level, I've tried ASB, all different types of CPAP. So, I've been through the gamut of different masks, everything. So I'm pretty sure, I've reached a level where it's kind of like a ceiling, a wall, where I can't get additional benefit from a CPAP. And but each of these gives a different kind of insight, and together they help paint a picture of what's happening in your airway. So we'll go through them one by one. So every time you see a new ENT for sleep disordered breathing, they'll probably start with an endoscopy. So basically it's a camera through your nose to look at your airway, and they'll check for things like a deviated septum, enlarged turbinates, tonsils, or areas of constriction basically. And it gives them a general idea, but it's obviously still a subjective test. So yeah, there are classifications of, say, tonsil and tongue size that kind of normalize them across the population. But those do help providers, assess the degree of hypertrophy or size of different structures relative to each other. But apparently its usefulness is debated. I don't know much about that, but practitioners are still in the end using visual inspection, which is inherently a subjective way of classifying something. So I kind of learned this the hard way, because when I first had UARS diagnosed and the CPAP wasn't working for me, I tried it maybe for 3 to 6 months, something like that. And I went to an ENT surgeon and they inspected my airway using endoscopy. to see where they could maybe perform surgery. And they said everything looked normal. There was nothing they could do. And I should just keep trying CPAP. You know, of course, I was pretty disappointed, feeling like I had no other option other than this subpar, CPAP treatment. And I didn't know about jaw surgery at the time. Had no idea that I could be a candidate. And I was pretty new to all this, so I didn't even think of getting a second opinion. So essentially, that one doctor's opinion based on an initial endoscopy threw me off pursuing further treatment for several years, and I was just kind of hanging on this CPAP, trying to optimize it, and it was never fully working. So eventually, I think by chance, I went to another ENT who did an endoscopy and said there were maybe 4 or 5 different sites where they might recommend surgery just based off of that endoscopy. So I was just telling that story because while endoscopy is super useful, I mean, doctors need to get a sense of what's going on by using that. It just depends a lot on the provider's training and interpretation and kind of what conclusions they draw from that. And another downside of an endoscopy, awake state one, is that it doesn't resemble the airway during sleep, of course. So as most of you know, when in deep sleep, muscle tone relaxes and the shape of the airway, it changes by a lot. But to get a better idea of what happens during sleep, some surgeons perform a DISE. So that's a drug-induced sleep endoscopy. And they'll use a sedative like, I don't know exactly how to pronounce this. It's propofol? Anyways, use propofol probably to put you in a sleep-like state and then perform the endoscopy. So usually an endoscopy, it would wake you up, obviously. So they need to put you into an artificial sleep. And during this, they'll move your head or body into different positions, most likely on your back to see how bad it is when you're supine, on your side. And sometimes they'll simulate a mandibular advancement device, for instance, by pushing your jaw forward, your lower jaw, and to see how it affects your pharyngeal airway. And if it gets better that way. And they'll usually try to mimic different depths of sleep using different amounts of sedative. So I've had a DISE done 4 times, once by an ENT just to get a general picture, once before major multi-level surgery, and twice again years after that surgery since my symptoms hadn't completely resolved. So were they helpful at all? Yes, I think they were, at least for me. And knowing what I know now, I'd be somewhat uncomfortable if my ENT hadn't performed the DISE before the major surgery. I'm just looking back. This is because apparently a DISE will give the surgeon a much better idea of whether A, non-invasive options might be worth a try first before surgery. So if a MAD device or a mandibular advancement device is likely to work. 2, whether they are indeed, targeting the right structures with the surgery. And 3, to rule out any contraindications of certain types of surgery. So apparently if there's a concentric collapse of the airway, so not just front to back, but laterally as well, then, for instance, a hypoglossal nerve stimulation device, I forget what they're called right now, shouldn't be used. And in general, soft tissue surgeries are then less likely to succeed, apparently. Still, it's not perfect, like with an endoscopy while awake. A DISE still depends on provider inspection, visual inspection, and evaluation, which is again subjective to an extent. But it also depends on the patient's own response to the propofol or whatever sedative is used. And some argue that sedatives don't quite mimic sleep's natural reduction in muscle tone anyways, and that it's really impossible to exactly dial in the right amount of sedative so that you're not overestimating the degree of obstruction or underestimating it for that matter. Still, a DISE seems really helpful and informative, especially if surgery is being considered. So something I didn't do until many years later, but should have arguably started with, is a scan of the upper airways that includes imaging of the soft tissues and bones. So if you have an obviously narrowed airway, a low radiation cone beam computed tomography or CBCT scan should help you tell and your doctors where the airway is most compromised. So using certain programs, one can measure the total volume and the narrowest part of the pharyngeal airway. You can also see in the nasal cavity if and where there are certain blockages, so whether that's enlarged turbinates or a deviated septum. And a CBCT scan is just a really easy way to visualize what's going on, but also an easy way to share this information across providers. And what's great about CBCT as well is that I think it puts into perspective whether your problem is or could be primarily related to soft tissue hypertrophy of different structures like your turbinates or your tonsils, or if there's an underlying skeletal misalignment or structural issues such as a recessed jaw. And I think that's a critical distinction to make because in the end, soft tissue surgeries have lower long-term success rates compared to the more skeletal approaches like maxillomandibular advancement. And again, I'm not one to make give medical advice because every person is unique, and I'm not a doctor. But just to make the point that what's important is sequencing and in those interventions and making sure not to ignore obvious skeletal misalignments that are contributing to sleep disordered breathing, because addressing those is often a more effective path than ablating, resecting, remodeling soft tissue. And there I'm speaking from experience because I've had 9 soft tissue surgeries so far, only to realize after I'd done them that I had underlying skeletal or orthognathic issues that I still need to address. And had I addressed them first, I think maybe I could have foregone or skipped those soft tissue interventions. Also, I had these multiple surgeries, which helped a lot for 2 to 3 years, so much so that I got off the CPAP for that time. But then my sleep got progressively worse again over the years. And I think this is because of just general aging-related decline in sleep quality, but also the tissue becoming more lax again over the years. So, I've been back on CPAP since last year. And just the general overall point is I think it should be routine for anyone with sleep disordered breathing who's considering surgery to get a CBCT scan to rule out or assess any skeletal issues and just to get a holistic picture of the whole case. And in my case, my scans revealed that I have a retrognathic maxilla, so in other words, a retruded upper jaw. And why was this missed for so many years? Well, for me, I'm not visibly retruded, or it's a bit hard to spot, and I'm not the obvious MMA surgery case. So you can't really tell that my maxilla is retruded unless you kind of look from the side profile and I smile. Maybe you can tell a little bit then, but my lower jaw looks fine. And the biggest giveaway really is my bite. So I can bite like this and make my molars touch in the back, but it's a bit uncomfortable. My comfortable bite is actually like this. And that's an edge-to-edge bite right there. And it's edge-to-edge with my front teeth compensated outward, where orthodontists, make your teeth go out a bit to make the bite, to align the bite essentially. So if my front teeth were decompensated, so made straight again, I would definitely be it would be more obvious that I have an underbite, a class 3, and my upper jaw could come forward a couple millimeters. And so, I never received a CBCT scan until I started consulting with jaw surgeon and orthodontists, and that's where it kind of became obvious. You can see that I have a retrognathic maxilla by lining up certain cranial structures or landmarks on these scans, and just by seeing where they are in relation to each other. So here's an analysis done by an orthodontist who classified me as moderately retrognathic, and this explains in part also just why my airway is so narrow at the soft palate or behind the soft palate. You'll see here the minimal cross-sectional area, or the narrowest part of my pharyngeal airway, is located here. And here in this image, measured based on the CBCT, anything in green is essentially good. Red and black, not good, very narrow. The downside, well, CBCT is still a static image, so it shows structure, not movement. And head position, tongue position during the scan really makes a big difference in terms of what the picture will look like in the end. But if done right, it's super helpful. And combined with the DISE, it can give a really complete picture if a DISE is indicated. Though for both and all of these diagnostics, really, it can't exactly tell which obstruction sites are contributing the most, or the relative contributions of different obstructions or issues in the airway towards contributing to sleep apnea or UARS. And next up is rhinometry, or more precisely rhinomanometry. So this measures the volume of airflow and the pressure difference across the nasal passage and it calculates nasal airway resistance. And it's nice because it's a quick, non-invasive test to quantify essentially whether your nasal airway is significantly obstructed or not. It's an objective measurement, and research has been done on essentially, I believe, tens of thousands of people to normalize the results across the population, establish reference values. And in other words, we know what results and values are okay and which require attention. So it's a nice, quick way to see whether your nasal breathing is something that would be contributing to, or is likely to be contributing to, sleep disordered breathing. Now, one downside is, again, it won't tell us about the relative contributions of different obstructions in the nasal cavity. And of course, it won't tell us about anything else that's happening in the upper airway, the rest of the upper airway, since it only measures airflow through the nose. But super helpful. I've had it done before, and it gave me just more confidence in ultimately deciding whether or not to address my nasal breathing. Now, something I came across a couple of years ago was computational fluid dynamics. And CFD for short is a simulation technique that's used in engineering to study how gases or liquids move and interact with their surroundings. So engineers apply it to understand aerodynamics of cars, the lift of airplane wings, or how engines are cooled. But it's also been used in biology and medicine. And when used to model airflow in the upper airway, CFD can provide a physics-based way to visualize how air moves through the nose and the pharynx. To make it, researchers typically start with a 3D anatomical model of the airway that's derived from the imaging, the CBCT scan or an MRI scan, it could also be that. And they use specialized software to then simulate the airflow under different conditions. And so far, CFD analyses have been used almost exclusively within research and academia. And I found just a couple applications where I thought, oh, that's very interesting, and I'd like to get an analysis for myself done. But I wasn't able to find any practitioner that was doing it, so I had to go online and find different consultants to piece together the different parts of this analysis, essentially. I failed quite a bit. Took me a long time, a good 6 months, and quite a bit of cash. But in the end, I had it, and it was pretty helpful. I was deciding between MMA and maxillary expansion, and just couldn't figure out what to do based on the available tools and diagnostics, the ones we've already discussed. And so this was just one piece of the puzzle, additional puzzle piece that helped me decide in the end. And here we can see some of the outputs, the pressure maps, velocity profiles, and flow streamlines that a CFD results in here. And explaining it all takes a bit more time and a bit of a crash course in airflow dynamics, which is why I want to make a future video on this to explain it in more detail. But yeah, for me, the CFD showed that my nasal breathing was pretty poor, in that, yeah, the area behind my palate is causing airflow issues, not just in that area, but further downstream in my airway as well. And then, just seeing the results visibly in this way made my whole case just a bit more tangible for me and gave me confidence in the way I was moving forward. So in the end, I decided with all the data that I had, not just based on the CFD, but with the scans, the DISE, the sleep lab results, that I would go for maxillary expansion first. Before an MMA, because I already had multiple soft tissue nasal surgeries, including turbinate reduction multiple times, a turbinate out fracture, repair of my deviated septum, removal of the adenoids, so I didn't want to go into an MMA and then not to benefit as much as I could, or experience a relapse after because of poor nasal breathing, or to still have sleep disordered breathing. And downsides to the CFD analysis are the obvious one, that is just not offered widely at the moment, and that is really not so much researched and tested in clinical applications as other approaches. So there's been some effort to establish reference ranges for measurements in CFD analysis and a bell curve essentially for the population, but it hasn't been done like with rhinomanometry, and we're still missing these kind of large scale studies in the same way that was done for that. And then another downside, or constraint rather, of a CFD is that it's going to be based on, again, a static snapshot of the airway in an awake state versus sleep, because it's based on a scan of the airway. But with technological advances, it should be able to eventually model dynamic airway changes at some point. So just model different shapes of the airway under different conditions, different head positions, and so on, and then model the effect on airflow. And I'm convinced that it's a really valuable tool. And over the past year and a half, I've learned how to conduct these myself. And I've been working with essentially a team of engineers to research it more, see in what ways it's useful, and hopefully bring this to more people. And ultimately, it'd be great, with more research to get this FDA approved and to make it more widely available and useful also in clinical practice. So your case might be more or less straightforward than mine, but I needed information from basically all of the above diagnostics, that we just discussed to get a grip on what my issue was. Partly because it was so hidden. My retrognathic upper jaw wasn't obvious at all, and it only became apparent once I had the information, spoke with the right providers, had the right diagnostic tools, and then I didn't know what to do about it until I started speaking with people online as well. Which brings me to the point of, regardless of your situation, you'll want to inform yourself. So speak with and see different providers, see an airway focused ENT, but also an orthodontist, and if indicated, maxillofacial surgeon. Get information from others online and try to make an informed decision. So I'll put some links on YouTube channels and Reddit forums in the show notes. And these are hosted by people who have a lot of experience and have helped me a lot, and the community of people as well. And some people make the point, that all this information can lead to information overload and decision paralysis because there's too much information out there, and we need to get on with our lives and let the providers decide what's best. And I think that's true to an extent. Like, we all don't have the luxury of time and resources to be dedicating to optimizing our treatment and finding the exact best thing. But it's tough because we're stuck with a condition that's under-researched and appreciated, at least if you have UARS. And obstructive sleep apnea can also be quite difficult to solve surgically, or in general with any kind of treatment. And from my own experience, I've had 9 surgeries and at most a modest improvement in my sleep. And I think I could have avoided some of those surgeries, had I invested more time and effort into the decision-making process. I think when I was making those decisions, not as much information was available online. So there is that factor as well. But now it is out there, and it's really helpful to inform yourself. But if I had to summarize from my experience and everything we discussed in this video, I'd say the following. So try CPAP first. It's the least invasive. Often it's quite effective. Sometimes it's not. But even if it provides partial relief, it can give you some temporary breathing room while you figure out the next steps in your treatment. Next, start gathering data through the different diagnostics we went through and try to rule out definitely any underlying skeletal and structural issues. So again, a CBCT scan can be very helpful there. Try to look for patterns across the diagnostics and tests. And finally, consult with different types of specialists. So an airway focused ENT, an orthodontist, and if needed, a maxillofacial surgeon. And for sure, get online and speak with other people who have been through this and see what their experiences have been, because that's been extremely helpful for me.